Good morning. Well, we are Team 3, and I'm Ryan, and I'm working with Michael, Matthew, and Leanne, and we will be presenting to you our findings for this case. So, briefly, just to start, kind of to set the gravity of this situation and set the tone for our root cause analysis, we'd like to start with some stroke statistics. It's well known that approximately 800,000 people in this country suffer from a stroke every year. This is becoming a significant financial burden for this country, specifically in southeastern Kentucky. One of the most compelling statistics that we came across was the fact that 2/3 of patients who suffer from an ischemic stroke end up being readmitted to the hospital or die within that first year after the stroke. Maybe less surprisingly, unfortunately, is the fact that many of these readmissions and deaths are from preventable causes for things like pneumonias, GI bleeds, and falls. So the overreaching theme of our talk today is going to be coordination of care. So the case of Lynette is a perfect example of what we're calling uncoordinated care. So this kind of problem can lead to increased morbidity and mortality for strokes, but is also applicable to a lot of other hospitalization causes. So our approach to this problem is to focus on the triple aim and then relate this the best we can to the root cause analysis in which we performed for the case of Lynette. So while our proposal specifically pertains to stroke-related care, we want to emphasize the fact that this can be applied to several other causes for hospitalization. We also want to emphasize the fact that while this is an incredibly complex problem, that what we tried to do is boil it down to things that we thought we could have the broadest impact on within this community. So the root cause analysis that we performed for this case really boiled down to poor coordination of care. And we tried to break this down into 4 subcategories. And the issues that we'll tackle today are issues with protocol, communication or lack thereof, lack of education, and then staff shortage issues. So throughout the presentation, you can refer to which category we're referring to in the upper left-hand corner. The next way that we kind of organized our thought process and want to guide you through our proposal is by identifying barriers to treatment. And we do this with this timeline here. So you can refer to which step of this process we're at along the way by referring to the upper right-hand corner of the next slides. So before we can better understand these barriers to treatment, we must first understand what qualifies as good treatment for stroke. So study after study has shown that time is of the essence. Large-scale clinical trials have shown that earlier TPA use or thrombolytic therapy results in decreased mortality and higher rates of discharge to home. Really with this, we're talking about a matter of minutes. So with every 10-minute delay in treatment within that first 3-hour stroke or treatment window, there's a significant decrease in quality outcome parameters. So now the first barrier to treatment that we come across is when the patient is at home. And really this pertains to patient recognition of symptoms and then taking the appropriate action once those symptoms are recognized. So what we propose to do here is continue what SDHN has already started, and that is with the purchasing of radio and TV ads that act as public service announcements, educating the public as far as what are these symptoms of stroke to recognize. Now our team reached out to a media buying agency and they provided us a cost analysis of how much it would cost to purchase these ads within Perry County. You can refer to our appendix for more details on this. This is a static image of what these advertisements would embody. Obviously, we go through what the symptoms of stroke are, but more importantly, what we want to emphasize is the aspect of time and how crucial this is for good patient outcomes, and the fact that they should call 911 as soon as these symptoms are recognized. The next barrier to treatment that we identified was with EMS personnel. So recognition of symptoms and appropriate triage is important not just for patients, but for the first line of treatment with EMS. So our proposal for this problem is to implement a pre-hospital stroke assessment tool for these EMS personnel to use in the field. So data has shown that when these protocols are implemented, that we can get patients to the hospital more quickly and these patients receive TPA more frequently. The next barrier to treatment that we identified is within the emergency department, and we have 2 proposals here. The first is triggering automatic order sets that will initiate as soon as the patient arrives in the emergency department. Kaiser recently did a large-scale trial looking at the efficacy of implementing such a program, and they found that upon implementation of a system like this, they were able to decrease mortality and increase the use of TPA. These order sets really are nothing novel. Really what they are is a checklist for emergency department personnel to use. And really it's more of a fail-safe mechanism so that certain aspects of quality of care don't fall through the cracks in a busy emergency department. Cost for this will start off as quite minimal, as we propose to use paper copies at first while we work on implementing this automatic order set triggering within the EHR. The next proposal within the emergency department is rapid involvement of therapy services, and specifically we want to focus on the involvement of speech therapy as it pertains to the case of Lynette. In our research we found that dysphagia was present in close to 78% of stroke victims, and obviously this is going to cause an increase in things like aspiration pneumonia. Aspiration pneumonia is going to fall under that category of those 2/3 of patients who have increased morbidity and mortality due to things that are preventable like pneumonia. So our proposal to integrate this therapy services more rapidly, we hope to decrease that 2/3 number. To talk more about the inpatient side of this, I will pass it on to Michael.
Thank you, Ryan. As we were performing our root cause analysis of Lynette's case, we pinpointed multiple factors and barriers that could have impacted her care during the inpatient setting, mainly focused around communication and education. So there was deficits in communication between the hospital staff, the patient, and the patient's family. For example, regarding the new diagnosis of stroke and diabetes and Lynette's understanding of her disease states. Also between various healthcare workers. This included the incomplete charting, such as the speech therapy orders that were not inputted prior to the discharge summary being sent to the rehab center. So I want to take a moment to talk a little bit about patient education and its impact on patient care. So discharge counseling and follow-up has been shown in studies to decrease hospital readmission rates and emergency room visits by up to 30%, and this is done by implementing a three-part method of teach-back education, discharge planning, and follow-up. We did a little research and we found that 17% of the population in Perry County are considered to lack basic prose literacy skills. This particular population may have difficulty doing things like interpreting what's written on their prescription bottles or understanding written information that's been given to them, or even setting up follow-up appointments with their primary care physicians. We know that stroke is a disease state that's greatly influenced by modifiable risk factors, such as compliance to pharmacotherapy. So what is STHN doing now to reach out to this particular patient population that has low health literacy like Lynette and much of the surrounding area? So they do offer some particular programs now. What we did notice is that they did not offer many at-home educational materials for patients to take home with them at discharge. So what we're offering is to offer free health seminars in various formats to help this particular patient population with low health literacy, or patients that may have difficulty transporting to the hospital to get back for some of this follow-up education. We'll do this through new informational written packets that are written at a lower health literacy levels that they're more likely to understand, through internet web-based programs such as webinars, and through free DVDs that they can take home with them. So the cost for a program like this, we estimate it to not be too expensive at all. We did a little research that it takes about $2 to $3 to burn a DVD, and then copy material, of course, would not be too expensive at all. Most of the material that we're planning on using is actually already available from a lot of non-for-profit organizations, and they're readily available to be modified and edited to meet our organization's needs. And the one part of this that could be expensive is labor costs. So we propose to keep labor costs low and to improve the relationships with the medical schools in our area is to utilize students and residents to help complete this process. So students and residents can be from various disciplines, so medicine, pharmacy, physician's assistants, and nursing, and the list can go on. And these students will prepare the material, they will distribute the material, and they can educate patients in the hospital and in the community. And of course, they'll be doing this under the guidance of their preceptors. Another barrier that we encountered when doing the root cause analysis was communication between healthcare workers. There was a breakdown in communication with the incomplete charting of the speech therapy orders. So the speech therapy orders were not inputted by the time of discharge. The discharge orders were sent to the rehab center, and then Lynette's care was delayed because her speech therapy orders never made it, and unfortunately she developed aspiration pneumonia while she was in the rehab center. So of course our long-term goal would be to have all STHN organizations become integrated with the same or compatible EHR. However, this is a very expensive process and could cost millions of dollars to do something like this. So in the short term, we're proposing to require a protocol change where all results and patient care notes are entered into the electronic health record by a specified time prior to the patient's discharge to ensure that gets transferred over to their discharge documents. And now to talk a little bit more about how case management plays an integral role in part of our plan, here's Matt.
Thank you, Michael.
Thank you.
So case management is an integral part of facilitating a smooth transition of care from the hospital setting to either an at-home setting or an inpatient setting such as a rehabilitation facility. Case management is also being used more and more to follow patients at home, both with hospital-based programs and insurance company-based programs. We propose an intensive RN-led case management program that will follow certain high-risk patients at home, as well as improving the current system they have in place. This will assist patients and their caregivers in more effectively managing their care at home. We want to make the patient an active participant in their care. We will coordinate care between different members of the care team as well as different facilities, and we will work to overcome barriers that may prevent the patient from receiving the care they require. Finally, we will adjust the delivery of the care to the actual needs of the patient. This will help prevent fragmented as well as unnecessary care and will reduce costs and improve patient outcomes. The research has shown that these intensive case management programs that follow these patients at home have saved about $3,000 per patient per year. This is over the cost of actually implementing these programs. In Lynette's case, she developed aspiration pneumonia because of poor continuity of care. This can cost $11,000 per occurrence. It increases patient morbidity as well as length of stay. And stroke readmission rates within 30 days of their stroke are 6%. The research has shown that half of these can be easily prevented by improving your coordination of care, both between the hospital setting and home as well as different facilities, and also making sure that patients make their follow-up appointments. Initially, we plan on evaluating these patients within 24 hours of their admission to the hospital. The case manager will use this evaluation tool to determine if this patient meets the criteria for enrollment in this high-risk case management program. We will make sure the patient is willing to participate in this program. We will look at the medical complexity of their case, such as do they have a new diagnosis, multiple comorbidities, or if they are taking multiple medications. We also look at patient characteristics, such as the amount of support or education the patient requires, if they're likely to miss doctor's visits or provider visits, as well as their likelihood to be poorly compliant with medication therapy. Finally, we will look at socioeconomic reasons, such as their financial resources or their living situation. When discharge is planned for these patients, we will communicate with all of the different providers of in-hospital services to determine the needs of the patient upon discharge. So, regardless of whether the patient is going to be part of our high-risk case management program, we will still facilitate this transition of care more effectively with better communication and coordination of care. If the patient, for example, is going to the inpatient rehabilitation setting, we are going to communicate all of those needs directly to that setting, to a contact person in that setting, so that all of those services can be arranged there. So, as in Lynette's case, a therapy service isn't missed, which leads to a complication. If the patient's going home, we're going to talk with the patient about their resources at home, their living situation, to determine how we can best fit the care to their situation. We will provide in-hospital education and continue that education at home to really reinforce that the patient understands how to care for themselves. We will arrange all of the different in-home services, and we will arrange transportation and make appointments for patients that lack that. This can be done in Perry County with public transportation, which is available. It's inexpensive. This may not be an option for all patients, though, and Perry County actually provides some free medical transportation to patients that qualify. So that is something that we can try and qualify these at-risk patients for. To follow up, we will talk with all of the in-home providers to see how the patient's progressing so that we can adjust that care to the actual needs of the patient. We will also talk to the patient to see if they feel they're receiving adequate care and how they feel about the program and how they're managing their health. We will ask them questions such as, are they taking their medications? Do they have any specific questions about their medications or health that the case manager can answer? We will ask them if they're making those follow-up visits, as well as are they getting all their testing done as ordered by their providers? Finally, we're going to ask them, are they managing their health effectively over just what their providers have implemented for them, such as are they improving their diet and exercising regularly? The cost of this program is $65,000 per year. We plan on hiring 2 case managers initially to each manage 100 to 200 patients depending on the needs of those patients. We will train these case managers on the needs of stroke patients, comorbidities that are common in stroke patients, and the services that are available both in the community and the network to best facilitate these patients' care in the most cost-effective manner possible. And now I'm going to hand it off to Leanne to speak about another aspect of the at-home care.
Thank you, Matt. So far, you've heard my colleagues speak about stroke protocol, patient education and communication barriers, as well as a case management implementation plan. But when we looked at Lynette's case at home, we found that it was an entirely unique problem. It was a lack of basic medical care. There was no staff to help her at home. We specifically decided to look at the physical therapy services as we felt that that had the most impactful influence on Lynette and her at-home care. There was a shortage of staff with Lynette to follow up with the physical therapy services, as well as within the small amount of staff available, there was no financial incentive to go to these faraway places as they were not being compensated for their gas mileage. And then with that lack of staff, there was no monitoring of the at-home rehab capabilities, meaning there was no notice that the floorboards were uneven or the presence of a dog, which are all high-risk factors for a fall. But instead of advising you all to simply do a massive hire of physical therapists, we wanted to dig deeper and ask, why is there a staff shortage in this area? And we looked into the local education and found that the cost of education was quite high compared to the average annual income of families. So our proposal was to do a tuition subsidization with a hospital contract, specifically to PTAs, physical therapy assistants. State law in Kentucky requires that PTAs are under the supervision of PTs at any point in their patient appointment. With that said, that can be done by telephone, email, and even text message, as long as there is a response within 12 hours of that current appointment. Additionally, a visit between the PT, the PTA, and the patient only must occur once monthly. And depending on the hospital's specific limits, Kentucky has a state law of a 4-to-1 PTA-PT ratio. So you can see by the PT annual salary nearing $80,000 compared to the PTA of $40,000, the cost benefit of investing in the PTA education locally. These are some local educations that we found. The first 2 were provided for us in the case study, and the second 2 we found upon research looking into the educational system in southeastern Kentucky, as well as some current hospital education plans. Again, this idea is not novel. This is a proven successful plan that is working at a federal and state level. And while these programs focus specifically more on medical students, we believe that we can prove to you the success of these programs and apply them to the PTA education system. So our solution is that the hospital invests in subsidizing educations for PTAs in the area. With the total cost of the program at Hazard Community Tech at nearly $13,000 with 25 students a year, we propose that the hospital offer a scholarship program of $100,000. In return, the PTAs in their clinical rotation of 600 hours required go to those rural areas, as well as give a 1-year give back to the rural areas in their career. This would allow, obviously, the PTAs in their clinical rotations to see the benefits of rural healthcare and the fact that you can see a wider population in a larger area of coverage with patients and possibly get to do more. Our solution is not just a Band-Aid. Our proposals are immediate, short-term, and long-term benefits, and as you can see where the proposals lie on the timeline as well as the cost. In an act to clarify, though, we've also given you a graphic representation that shows that better care does not need to cost more. That the standard of care on the left with the readmission rate of 14% compared to the standard of care with the readmission rate cut in half with the implementation and the cost of our plan, you can see again that it does not cost more to give your patient better care. In fact, you could be saving hundreds of thousands of dollars. We will assess this at 6 and 12 months, as well as 3 months retroactively to make sure that our assessment is accurate. We'll be looking at hospital statistics and patient satisfaction. And in summary, you've heard it from all of us. The lack of coordination of care was the major problem that we found in Lynette's case. We have a 4-pronged approach that looks at protocol, staff shortage, communication, and education in hopes that we are targeting the triple aim of improving our patient care, improving the community health outcome while saving a bit of money as well, in hopes that cases like Lynette incidents will decrease, just not in Lynette's case, but all across southeastern Kentucky. Thank you. Questions? We come to the center.
Sure.
Kind of centered.
First, I guess a couple of comments. I think it was very helpful to, in your effectively your fishbone diagram, your root cause analysis, to see these issues and then to track them across time. So I think that was very well done, a nice way of us understanding exactly where you were targeting and why. So that came together very, very well. One of the things we did ask you to do, though, is to give us some comments on whether we should, what level of risk assumption we should be getting involved in here. And I didn't necessarily, I don't think I missed it, so I don't think I heard that per se in your presentation. So thinking being, do we stick with the current kind of fee-for-service related system, or do we look at some sort of reward sharing, et cetera?
I think.
Did you have some thoughts there?
Yeah. So we had thought that since we are taking on all of these different aspects of the at-home care, we thought like a bundled care arrangement would be probably a way to take on the cost of it, because then we could see savings if we improve the outcomes of these patients.
Okay.
So that was, I think that was our take on that.
Right.
Okay, fair enough. I like the educational focus. Obviously, you went out and you tracked and said where are the resources there, and the engagement of students was one point, et cetera. What, we always, the triple aim, as I've come to understand it, focuses on patient and family. And it seems to me family is an incredible resource. I mean, in fact, in my own kind of personal effort here, I don't think patient. I think patient and family every single time. So I think your thoughts on the use of family to support all of these very, very good recommendations. Where are you there?
Yeah, I think that you bring up a great point, and the material that we're proposing, the new at-home material, the DVDs, the webinars, I think all that is information that the family can utilize as well to better understand the disease state, and then be that support system around the patient. Because, like we said, the triple aim is it involves community health as well, and patient's family is part of the community, and bringing it all back together. And
that's really why we wanted to emphasize taking a lot of this educational material home, because a lot of the family isn't going to be in the hospital when this is presented to the patient for the first time. It's an incredibly overwhelming experience, not just for the patient, but for the family as well, and it can be a very confusing time. To give them these materials and send them home with them and let them watch them on their own time, kind of the comfort of their own home, in a little bit more relaxed environment, we hope to have a better impact as far as improving family education, and then they can share this with their community and kind of spread the knowledge, if you will.
Excellent, thank you.
How would you measure patient satisfaction with care and patient metrics following care for stroke?
What was it?
How would you measure? I missed that in the presentation. How would you measure the patient's and patient's family satisfaction with the level of care?
I think similar to any kind of analysis, you would do some sort of survey. I would definitely advise that there would be a separate survey for the patient and then the family, just because there obviously is different emotional attachments to the disease state and what's going on there. I would also advise for when they come back in for the case management and when they are meeting with the case management, we would obviously look at just the basic number statistics of are they being readmitted. So that would be just a telltale sign that they're obviously satisfied in the fact that they are not being readmitted. And then in terms of the emotional support and the continuation of care, that would be left up to the case manager to assess on a personal basis with the client, with the patient.
Yeah. I think the case management, the follow-up at home, contacting them, just communicating with them about how they feel their care is going is a big part of that. Just so the patient realizes that somebody cares about them, someone's looking out for them, and that they have a contact they can speak to who understands their case and what they're dealing with.
I think the patient satisfaction surveys, we've all seen them in the hospital. I think that to continue those on post-hospitalization is just as important, if not more important, because that's where a lot of the work is done. once the patient leaves the hospital as far as preventing them from coming back in. And we want to know the quality of the care that they're receiving at that time point, not just in the hospital. So continuing those surveys along our timeline is, I think, a really important part of our plan.
Yeah, which would be facilitated in most part by the case management that will be following the patient after their discharge.
And can you share with us a little bit more about your thoughts about EMS transported time criticality, and would you recommend to the county that they try to develop? Do they have the case volume, and would they try to develop a Joint Commission certified comprehensive stroke center, or would you try to arrange for air transport if endovascular therapy were needed to the University of Kentucky? What are your thoughts about that?
Yeah, so one of the interesting statistics that we came across is that 2/3 number, patients that are readmitted or die within the first year, that is not relevant. I mean, it's the same across all levels of care as far as stroke centers are concerned. So that 2/3 of patients readmitted and die within the first year, that's the same at your high-level stroke facilities as it is with your community hospitals, which I thought was incredibly interesting. So as far as developing this with the EMS personnel, as far as triaging these patients to see which ones to take to certain places, that was a bit more complex than we were willing to take on for this time period, and that's certainly something that came across our process of thought here, is what to do with some of these more complex cases. I think that's where this protocol, this pre-hospital assessment tool, can really be utilized to its fullest potential. You can kind of hammer it down to some more detailed questions to perform in the field, and then kind of triage these patients accordingly that way. Just to start with, though, I think we want to keep it to the basics of making sure that these patients aren't kind of lost in the fold, or that more patients are being brought into the ED with strokes that aren't really strokes. So that's where this protocol tool is going to be used at first. But we certainly see the value in expanding upon this in kind of triaging these patients to higher level facilities as far as stroke treatment is concerned.
In your cost-benefit analysis, you target a 50% reduction in readmissions as some of the justification for the costs. Can you tell me where you guys, how you came to that 50%, and talk a little bit about what challenges you think we're going to have as a network hitting that target of 50% readmission reductions?
I think that just from the research, when you start implementing programs like this, you generally see at least a 50% reduction in, say, readmission rates if you have a good system that works well. So that's where we came to that number. And a lot of those numbers I found actually, or that we found, were actually even more than 50%, but we put that in as a good goal just to shoot for to start. As far as some of the problems I feel like we would face in this is just probably the patient population would be a major problem, really getting them to buy into this. As it said in the case study, a lot of these patients have a mistrust of health care and they're self-reliant. So just really getting them to buy in, I think, is a big part of that.
With that being said, the community health programs that we're proposing and the at-home education to kind of help reach this patient population with the lower health literacy, I think would make a huge impact in our case.
As well as I think that following them at home is a big part of it, that they, again, just that they know we're looking out for them, that we're, trying to deliver the care in the best possible way that meets their needs, because every patient's different. So that's why having someone who's good at that, really adjusting it to the specific patient, will help that patient do better, I feel.
Okay. Yep, 1 minute. I'd just like to add on to that really quickly. Right. In the at-home, we saw that the preventable causes were pneumonia, GI bleed, and falls. And so at the at-home with the PTA plant proposal, you would have someone monitoring that. So that is, 1/3 of these preventable causes, someone eliminated in hopes that that would be monitored early on, and that if that was an unsafe atmosphere, that she would either be taken out or the family would be involved in making changes in the home for a safer environment. So our protocols did try to kind of tackle 2 of the 3 with the pneumonia and falls, in hopes that kind of those problems at least would be a little bit diminished.
Well, and I feel like GI bleed is kind of addressed too, because if these patients are on anticoagulation therapy, and we're following up to make sure they're getting their testing, that's something else that we can address, because a lot of the reason that they have issues like that is because they're not getting their INRs or whatever drawn on time, and then they end up with a really high level that leads to a bleed. So I think that's another way that we're hitting an aspect of that.
Okay, feedback now.
Great job. You obviously put a lot of time into it. You guys look great. You look very professional. The presentation was really nice. I guess, as Rick said, I liked. You did a good job of describing your thought process and your analysis. And I fall prey to this. One critique I would have is, I on one hand, I liked the icons that told us where we were, but on the other hand, it added 2 new data points to already sort of data-heavy slides, and there was a lot of information on every slide. So just stylistically, sometimes I do that too, but you can put a lot of information on a slide. And I also, I felt like you maybe could have led with the overall proposal and then fleshed out the detail. You sort of gave us the analysis and the pieces of the proposal as you went along and then wrapped it up, which I understand that approach, but for me, I was kind of waiting. I was kind of lost a little bit until we got to the end and had to kind of go back and rethink. And overall, a really strong presentation. I liked your focus on the acute care aspects. That was really good and detailed, and I thought well researched.
Thank you.
Nice job. And I particularly like the fact that you dealt with the EMS, the pre-hospital environment. I think that's a critically important component of this, because if we can change the culture of the community and educate the community, we still have to deal with maybe the 20% of patients who are going to have a stroke in spite of the educational and community effort. So in their time criticality is key, and I think involving EMS in the pre-hospital environment is important. I like the fact that you inserted cost effectiveness and the cost of your different recommendations. My only suggestion would be, it would have been nice for me to see at the very end of the presentation kind of a wrap-up of the return on investment based on the cost, a summary of that from the cost aspect. That would have been helpful. But overall, an outstanding job. Really good presentation. Thank you.
Thank you.
Well, you're going to see some diversity in judges here, because first of all, one thing we do agree is a good job, really good job. I liked the root cause analysis. I frankly liked the fact that you color-coded and you were referring to each of the barriers and defect categories in terms of where your solution. That was systematic. I enjoyed it, and I thought it was worth doing very much so. And I like the fact that you took these defects and you literally almost created a process map in terms of location and time, and that was very, very well done. And I think grounding, here's what we think we ought to do at each of these points. What I would have enjoyed is saying, now, if this had all been in place, what would Lynette's experience have been? That would have kind of brought it home, with the case with Lynette. We spent so much time seeing that. Because if you look at the end of the case, where is she? She can't afford what's needed. She's just sitting there. So, your case manager would have intervened, et cetera. Anytime you say patient, say family. That's just a rule. And if you read the triple aim literature, they talk. It says patient experience, but it's all about patient and family. And the family will be in the hospital. They will be looking at that initial form of the assessment form and giving feedback, and they're very key to the discharge planning process. So I think the family focus is important in addition to the patient focus. Very good into the clinical focus was very strong. I mean, I think you got into the disease process and various complications, et cetera. And I thought that was really good. We as a, now I'll role play, but we as a network board, again, we've got all these components who are trying to bring together not just the hospital, but all these other pieces. This question of risk assumption is a tough one, because if you build a really good system of care, then you're going to start getting, the people who are at risk are going to choose it. And there are financial implications to that. So this whole issue of risk assessment and, what your revenue going to be and what's your relationship, what data you're getting from Medicare. One of the issues with ACOs is the timeliness of the data to understand just what's going on in the population you're serving. So I think that from this kind of a board, it would be, what should we be doing? And I think that would have been worth a little bit more focus, very frankly. But I think a very professional job and very, very thoughtful, and I really did love the overall focus across.
Thank you.
Your thought?
Yeah, I did. I gave him mine.
I think I already gave him my thoughts.
I said any other thoughts.
Oh, any other thoughts? Oh, no, I agree with Rick. I take everything back.
Thank you very much.
Yeah, thank you.
Thank you very
Thank you.
much. Thank you.